Morning to others. This is Clyde Yancy. I am a longstanding AHA volunteer and a member of the advisory group for Get With the Guidelines Heart Failure. It's been my pleasure to be a part of Get With the Guidelines literally from inception, and I'm so pleased that Get With the Guidelines Heart Failure is now well in excess of 1.5 million patient records, and we're at least penetrating one half the country by virtue of hospitals. So I really want to offer my thanks to so many of you for embracing the philosophy and the initiatives reflected by our quality improvement program, otherwise known as Get With the Guidelines. I'm pretty confident that we've improved the quality of care for heart failure and that we've saved lives. In the spirit of doing that, we'd like to continue to stay abreast of new developments as they occur. In particular, we've struggled with heart failure with preserved ejection fraction for many years, but now we have evidence-based therapies that can change that natural history. The most exciting of those is the incretin-based therapeutic paradigm. And so for 2025, for this webinar, we want to challenge everyone to start thinking about what we would call a fifth pillar. You know the four pillars, but now we think there's a fifth pillar in heart failure that we need to consider. I'm delighted that this webinar will be supported and moderated by Dr. Kazi. I'll more formally introduce Dr. Kazi in just a minute, but the two of us have met several times and put our thoughts together to try to bring the most succinct information to you so we can all be facile with the themes and the subject matter necessary to consider incretin-based therapy as a foundational approach now, particularly for heart failure with preserved ejection fraction. So welcome to this webinar. I'm delighted that we have almost 200 participants, and I know that a participant might mean an entire group. So there may be several hundred listening in, and I hope these numbers continue to increase. Let's continue to move forward now. This is our portfolio of Get With the Guidelines. This conversation today is specifically about Get With the Guidelines heart failure, but that's not the entirety of what we represent. We represent Get With the Guidelines atrial fibrillation, stroke, especially with some breakthrough discoveries occurring in that particular quality improvement initiative, Get With the Guidelines resuscitation, and formally Get With the Guidelines coronary disease. It's been our intent to bring evidence into practice and then bring practice to the bedside so we can improve the care of patients that have heart disease. This is my introduction. We won't belabor the point. Just know that I've been a longstanding heart failure investigator and leader, longstanding AHA volunteer, and a former AHA president. We will belabor the point a little bit from my colleague, Dr. Kazi. He is a health economist as well as a cardiologist, extremely well trained both at the Harvard School of Medicine and the Harvard T.H. Chan School of Public Health. He brings really crisp expertise, understanding issues like cost effectiveness. We will address this as time goes on. You can see that he spent some of his time at the London School of Economics, so he brings significant expertise and holds a master's degree from that experience. He also is an expert in real-world data modeling and real-world data and mathematical modeling, so I'm delighted that he's working with us in today's webinar. Neither one of us has disclosures of any reference. Let's begin. For some time, the treatment of heart failure has really been guided by the outcomes of clinical trials. Very important constellation of these trials, published in 2022, captured over 3 decades of randomized controlled trial experience. One can argue that heart failure may have been one of the early platforms to incorporate randomized controlled trials as a means of securing the best evidence, starting in the early to mid-1980s. I won't say that heart failure was first, but we were amongst the first to bring this to bear. You can see the portfolio of clinical trials that emerged, but from those clinical trials, some of which were negative, we've been able to define a strategy for where we are today. Early this calendar year, we had an opportunity to speak specifically to where we are today by taking what's known as a century view. This was in concert with the centennial celebration of the American Heart Association, and I had the humble opportunity to speak about heart failure from a century perspective. This is what we put in writing, but what I will emphasize is the last sentence. We've come far enough in our discovery of evidence-based effective medical and device therapies that failure per se is no longer an inevitability. That we have the therapies to counteract any construct of failure, relegating that just to those that have the most severe disease. For virtually all other patients, we have an opportunity to fundamentally change that natural history. Here's the case in point. If we think about HFrEF, reduced ejection fraction heart failure, going from the consensus trial and working through the SGLT2 trials, I want you to pay close attention to how dramatically the outcomes have improved over the decades that we've been doing this work. In panel C, I've shared with you the relevant trials in HFpEF so we can know where those set points are as well. If you look at this very carefully, you see the arrow. That is a stunning decrement in the risk of death responsive to the incorporation of evidence-based therapies. This is something we should celebrate, recognizing that we fundamentally changed the natural history of this condition, but there is still residual risk. Nevertheless, what we know now has allowed us to develop this construct of the four pillars of effective medical therapy for heart failure with reduced ejection fraction. Many of you approximate that to GDMT. Let me remind you that GDMT actually means guideline-directed management and therapy because it's important that we not overlook the devices. It's important that we not overlook treatment of the comorbidities. It's important that we not overlook the benefit of lifestyle and cardiac rehab. So there are four effective pillars that are medical therapy. That's RAS inhibition, particularly the RNA compound. That's the evidence-based beta blockers. That's the mineralocorticoid antagonists, and in a very exciting way, the sodium glucose cotransporter 2 inhibitors. I always emphasize the graphic in front of you, in front of every audience with whom I have the pleasure of speaking about heart failure. We look at this probabilistic modeling exercise. The asterisk that you see here reflects the information that patients still bring to the office for their initial visits. With the diagnosis of heart failure, they all expect a 50% chance of death at 5 years. That is no longer the case. If you look at this modeling exercise, we can now see that asterisk has moved out to 10 years. This is substantial improvement. There are very few disease processes, particularly chronic disease processes, about which we can articulate such a substantial improvement and the ability to extend survival and concomitantly improve quality of life. But we have this next issue. We have this residual risk. And particularly for HFpEF, we are in a scenario where we have to consider what else is there. And so what I'm suggesting to you is that there's a fifth pillar that we need to consider. What is that fifth pillar? Well, Dr. Kazi and I both share a very strong academic interest in this whole space of incretin therapies. Again, Dr. Kazi's perspective is using real-world data analytics and mathematical modeling. Mine is understanding the translational science and trying to appreciate why might these therapies have some benefit that otherwise seems almost inexplicable. One of the pioneering scientists and translational investigators in this space is Daniel Drucker, and we make reference to his work in a very liberal way. But the focus of the next 15 to 20 minutes really is about what some are calling the GLP-1s, or the glucagon-like peptides. It's glucagon-like peptide 1, but there's also glucagon-like peptide 2, and there's another one called GIP. To give you the big summary, we know that these GLP-1s are associated substantially with a reduction in body weight, an improvement in hemoglobin A1C, a reduction in steatohepatitis, in a very provocative way, a reduction in the burden of cardiovascular disease. We believe much of this is mediated through a reduction in inflammation. And what's really exciting on the horizon, we should anticipate testing to understand whether or not this reduction in inflammation also leads to a reduction in neurodegeneration. So much so that phase 3 trials are underway with the incretin therapies in a setting of Parkinson's disease and in a setting of patients that are at risk for cognitive decline. So this field is continuing to expand. Now, let me go back and share with you some of the biology. We need to recognize this. If you've had a meal today, fundamentally your physiology has dealt with the homeostasis in blood sugar determined by the balance of glucagon, which raises glucose, and insulin, which lowers glucose. It is so primal to the survival of the species that multiple modulating proteins have evolved that allow exquisite control of blood sugar. So that as soon as glucagon is released, there are glucagon-like peptides that modulate the effect of glucagon, that is, suppress its effect and increase the production of insulin. The prototypical glucagon-like protein that is initiated when glucagon is released after a meal is glycinin. But after a series of metabolic steps, it yields GLP-1 and GLP-2 in particular. At the outset, we thought that everything about the biology of glucagon was limited to the pancreas. But now we understand that's not the case. We know that there are receptors in the brain. It's in fact those receptors in the brain that reduce appetite and lead to the weight loss. But pay careful attention to panel B. It demonstrates the insulin response to either intravenous glucose administration or oral glucose administration. All of you remember the prototypical glucose tolerance test. That biology is very exquisite and is driven not just by insulin, but by glucagon and these glucagon-like peptides. Now, what makes all of this fascinating is that when we think about the GLP-1s and realize that we are stimulating our hormone, remember, in heart failure, traditionally for decades, we've tried to antagonize neurohormonal activation. Here we're stimulating a hormone. This hormone, GLP-1, has a portfolio of effect that touches multiple organ systems. We'll talk about the heart later, but look at the effect on platelets, on the intestine, delayed gastric emptying on the stomach. Fascinating data on what happens to inflammation in the liver and steatohepatosis, even though there aren't GLP receptors in the liver. Fundamentally, what happens in the pancreas, we've already explained, in the brain, the blood vessels. We have the first clinical trial, in fact, looking at peripheral arterial disease in response to GLP-1 administration. And then there are intestinal lymphocytes, which are also involved. This may seem far afield from heart failure per se, but actually it's not. Because what we're suggesting to you is that there is this explosion in biology that's giving us a brand new treatment paradigm for diseases, Inc., that is, diseases across the board, cardiac diseases being the lead one and the topic of today's discussion. We also need to understand that these compounds didn't just arrive. They've been under active investigation for over 20 years, starting as just a focus on diabetes management, but then yielding these outcome trials that almost inexplicably showed a reduction in cardiovascular events, and now a series of more specific cardiovascular trials that we'll review in the upcoming minutes. In addition to the work that's been done with HFpEF, I've shared with you that there's at least one trial that's already reported on the benefit of GLP-1 agonists in peripheral arterial disease, diabetic kidney disease is under investigation, exciting work looking at liver disease, steatohepatosis, and potentially breakthrough discoveries in the neurodegenerative disorders. What's happening here? Many believe that weight loss drives much of this. And I'm sharing these data with you so you can see all of the developed GLP-1 agonists with the exception of the combination therapy. and a comparison of the effect on weight loss, it's been semaglutide, where we've seen the most profound weight loss. But Dr. Kazi and I will make an argument that there are benefits independent of weight loss that are attributable to exposure to these GLP-1s, and that may be the most exciting thing in heart disease. So is there such a thing as a fifth pillar? You will remember in heart failure, we've always thought about either using inotropes to make the horse work harder pulling the wagon, or unloading the wagon to make things easier for the horse. But we've never thought about fundamentally changing the wagon. We can fundamentally change the wagon by using these GLP-1 agonists. That's what's most exciting here. Going back to Drucker's work, let me explain why this is so exciting. We believe that there are GLP-1 receptors through the vasculature. These GLP-1 receptors in the vasculature, we believe, are responsible for these exciting reductions in major adverse cardiovascular events seen initially in the diabetes trial. One can't replicate these kind of data easily. It's very clear that there's been a reduction in non-fatal myocardial infarction, a reduction in cardiovascular death, a reduction in non-fatal stroke when the GLP-1 agonists were used in the setting of type 2 diabetes, and subsequently realizing an improvement in cardiovascular outcomes. We know that there's a difference between animal models and humans, but here is the most exciting piece. We do understand now that in the human heart, there are GLP-1 receptors. That's profoundly important because that tells us that when we upregulate the glucagon-like peptide 1 compound, we're actually stimulating these vascular and cardiac receptors. What might be happening? Well, the first thing we know is that there's an increase in LVF, and there's a decrease in LV remodeling, what many of us have traditionally described as reverse remodeling. We know that there's a protection against ischemia, at least in animal platforms. We know that there is a decrease in cardiac fibrosis. That's a pause moment because cardiac fibrosis, we believe, is a major contributor to the pathobiology of HFpEF. There's also a decrease in the release of the natriuretic peptides. There's a decrease in inflammation measured by TNF-alpha, a tumor necrosis factor. There's an increase in protein kinase. There's a decrease in apoptosis, and there's an increase in myocardial glucose uptake, which is the preferred fuel for the myocyte. If we can replicate this biology in humans, it gives us plausibility. When I say plausibility, I mean understanding what some are calling MOA, or the mechanism of action. Why is this so important? Because as we speak today, none of us can definitively tell you the mechanism of action of ACE inhibitors for heart failure. None of us can definitively tell you the mechanism of action for beta blockers and heart failure. But this biology is so important because it gives us a rationale. It gives us an opportunity to understand why these agents may be of benefit. So at this point, Dr. Kazi and I will now transition and start to talk about the clinical trials. But before we do that, I want to invite Dr. Kazi to just comment on the development of these compounds, this exquisite biology that gives us the impetus to continue to test it, and particularly if you've entered any questions in the chat, we don't want those questions to go unanswered. Dr. Kazi, your feedback at this point?
No, this is great, Dr. Yancy. Thank you for having me. I want to encourage folks to put questions in the chat. I don't see any open questions right now. I did want to say one of the fascinating things for me as a clinician and a real-world evidence person is that it feels like some of these benefits feel weight dependent, and some of these from the data appear to be weight independent. And we'll explore this further as we go along. Even within the cardiovascular spectrum, some benefits appear to be very tightly linked to weight and others don't. Dr. Yancy, what's your take on that? Just further downstream, but mechanistically, whether it's weight dependent or weight independent.
Well, it's a great segue to talk about the SELECT trial, because if we get into the SELECT trial, what I'll share with everyone is that what is so dramatic, and I'll pause after this and have Dr. Kazi comment, but these curves began to separate before there was significant weight loss, meaning that the benefit on this composite endpoint was evident, and it was evident way before the weight loss would have occurred. And it was most evident actually in the patients that were not morbidly obese. So it really does make the argument that the profundity of this benefit was driven by these receptors that we've tried to argue are in the vasculature within the myocardium that are responding uniquely and independently to exposure to the GLP-1 agonist. And again, Dr. Kazi, because the benefit wasn't quite so profound in those that were morbidly obese, it tells me that obesity is just a surrogate marker for the cardiovascular event, but there may be a biology going on, and I'll have you weigh in on that.
Yeah, exactly. Select is the one example that comes to mind where the curve separates early. As a reminder, everyone, Select was a trial of secondary prevention in individuals with a BMI over 27 and a comorbid condition, or over 30. You had to have pre-existing cardiovascular disease, and you see these curves separate right away. The fact that we think some of the cardiovascular benefits are weight independent has both clinical and research implications in my mind. From a research perspective, it would be there's a potential that we could achieve this using another agent that doesn't affect weight for individuals who are normal weight or lower BMI. So that's an avenue to think about in the future. But I think from a clinical perspective, that so much of the national narrative on GLP-1s is tied to weight loss. And so you might see an individual who's like, well, I don't need to lose weight. Or you might see someone who says, well, I didn't lose weight with GLP-1, so maybe I can stop them. And in contrast, what we're seeing here is that the cardiovascular benefit is, at least in this subset, which is about 8 million US adults, is maybe definitively independent of weight.
So to make that very practical, we now are up to 235 sites that are on this webinar, so thank you for joining. At each site, again, there may be more than one person listening in. Data being what they are, remember that the entry criteria here did not require obesity, just overweight. So it's quite possible that half of us that are on this call qualify as being overweight. If you think about that, if any of us have the pre-existing conditions, including hypertension, there is a potential benefit of exposure to the GLP-1 therapies on this primary cardiovascular composite endpoint. We said then in 2023 and maintain now that this really represents a breakthrough trial, landmark data, and these drugs, incretin therapies, very well could be the statins of this generation. But let's continue. Because one wonders, particularly given the framing that Dr. Kazi provided, that is a pre-existing cardiovascular disease, was any of it heart failure? Turns out the answer is yes. Now, because of the statistical analysis plan, something that Dr. Kazi and I significantly respect in the design of clinical trials, after the first secondary analysis didn't achieve significance, p-value 0.07, none of the remainder was subjected to a statistical test. However, if you look at the hazard ratio for heart failure, highlighted by the blue arrow, and look at the confidence interval, there is a strong suggestion that heart failure, agnostic of ejection fraction, might have benefited in the SLUG trial. Again, those data are 2 years old. But let's get away from kind of heart failure in the more generic terms. And let's, again, go to 2 years ago, exactly 2 years ago, September 2023, and think about STEP-HFpEF. In STEP-HFpEF, the goal was to administer the drugs, assess quality of life, several biomarkers, and obviously weight loss in an obese population with HFpEF, a phenotype that we've always argued is key. Not surprisingly, the trial was positive on a change in body weight, but surprisingly, it was quite striking on a change in KCCQ measurements. Now, if any of you are facile with KCCQ, you realize that the minimus requirement for an improvement in quality of life is about 4 units. This was nearly 8 units. So this was a substantial benefit as measured by a standard of measurement for quality of life. What about pooling these data with STEP-HFpEF in diabetics? This is the meta-analysis that provided a profoundly new bit of information. Yes, we saw the change in weight loss again, and we saw the improvement in quality of life, but we also saw a reduction in cardiovascular events. This was such a provocative finding, and the differences were so great that the ongoing summit trial using tirzepatide changed the primary endpoint with the anticipation that perhaps these drugs would do more than just improve quality of life, that they might actually improve the natural history. And here are those data. Tirzepatide acted in a profound way on the combined endpoint of heart failure hospitalization and cardiovascular mortality. This is another pause moment now for me to invite Dr. Kazi to comment on this portfolio of clinical trials, starting with SELECT, with these large signals suggesting that we can change the natural history of heart failure. What are your thoughts, Dr. Kazi?
Yeah, these were a couple of very exciting trials when they first came out, and I point out a couple of things. One, there was a question in the audience about how do we tease out weight dependent versus weight independent effects, and here's an example where, in contrast with the what we saw in Select, where the curve separated immediately, you see the curve starting to separate around 6 months, and 6 months is when, if you're on GLP-1s, you start to see meaningful weight loss, and so to me, I took this as saying at least a chunk of the HFpEF benefit is weight dependent, different from the ASCVD benefit we saw in Select that was weight independent. But also really important because, unlike the previous trial that we looked at, which was a KCCQ, like a functional trial, here we're like materially seeing a sustained change in heart events. And so very exciting, both as a clinician and as an economist, because you know this is going to matter in the long run.
So I want you to continue to help our audience frame this correctly. You and I were both together in Madrid at the ESC meeting, and we witnessed new information that
Yeah.
represent real world data in the setting of HFpEF, looking at incretin therapies, because a naysayer could easily argue, okay, these are controlled clinical trials that are industry supported, et cetera. But real world data give us a different perspective. Why don't you summarize what we saw in Madrid?
Yeah, I think thank you, Dr. Yancey. The one of the things about GLP-1s that I know that folks who've worked with these drugs know very well is that adherence is a challenge. A lot of people start these therapies and then either come up upon clinical side effects, and we can talk a little more about what the reasons are, but will discontinue therapy after a short period of time, even though these are meant to be lifelong drugs. And so for me, I am interested in seeing not just what happens when people receive these therapies in the control environment of a trial, which is really important because it tells you a little bit about the biology of these drugs, and but also compared with what happens when in the real world, when in the messy systems that we operate in, where people come on drugs, come off drugs, etc. And what was really impressive is that a group of colleagues at the Brigham ran this. What we call target trial emulation, meaning they're using observational data, claims data, EHR data to emulate these target trials, the two trials that you just looked at, and found the following: A, that the trials were very much replicable, meaning the methods worked. And then once they use those methods to say what's actually happening in the real world patients with HFpEF, they found very similar results, about a 40 to 50% reduction based on in heart outcomes based on semaglutide or tirzepatide relative to one of the gliptins that they used as a control, which we know that the gliptins don't affect heart failure outcomes. They didn't see a difference between semaglutide and tirzepatide. So one of the advantages of real world evidence is you can do head-to-head comparisons that trials are unlikely to do, or it would take a very large trial to do that. And so while that comparison in the real world was underpowered, it's reassuring that these drugs appear to be somewhat interchangeable for HFpEF.
So I hope that that stimulates even more discussion as we get closer to the end. And please do put your questions in the chat. But let's continue this because now we are going into a role where we're thinking about what are the clinical benefits of these drugs, particularly in the setting of HFpEF. And courtesy of our great colleague, Dr. Fonero, we've got some new envisioning of what all this could mean. So look at the construct of this table: major adverse cardiac events, heart failure hospitalizations, and chronic kidney disease progression. Thinking about HFpEF therapies, let me have you start at the top of the graphic, looking just at the SGL2 inhibitors. These drugs have a class 1 indication. These drugs work very well. When we think about going beyond the SGLT2 therapies and now adding the non-steroidal mineralocorticoid antagonists, and then continuing to the bottom, where is SGLT2, plus the GLP-1 receptor agonist, the incretin therapies, plus the non-steroidal mineralocorticoid antagonists, I want you to look at how heart failure hospitalizations become even more powerfully impacted, major adverse cardiovascular events are slightly better, and chronic renal disease progression is profoundly impacted. This is the kind of portfolio of therapy that could fundamentally change the natural history of patients with HFpEF. Dr. Kazi, for someone like me that's been in the heart failure space for over 30 years, when I see something like this, I really have to stop and catch my breath. Because for HFpEF, for too long, we've talked about treating the comorbidities and diuretics and controlling hypertension. And if you train your eye to that lower row, these three agents, cost being an issue, admittedly, offers us an opportunity for HFpEF to do what we've done for HFrEF. Just as a clinician, please give me your response to this.
Yeah, a couple of things. One is I totally agree. These data, if I understand them correctly, are for the subset of folks with HFpEF and diabetes and kidney disease,
Right.
which is our highest risk subgroup, both in terms of heart failure outcomes, but also in terms of atherosclerotic outcomes. As most people in the audience will know, kidney disease is a very powerful predictor of atherosclerotic outcomes. And so in that very high risk group, this relative risk reduction almost undersells the value of the therapy, because if you start out at higher risk and you have a large relative risk reduction, you have a very large absolute risk reduction. And so these are pretty substantial benefits that we expect to see in these patients. I think it's also interesting because I've always thought of HFpEF as a very heterogeneous group, and to have the risk of an outcome in a very heterogeneous group means there are some people who are deriving a very, very large benefit. And that's, again, a question for future. I don't want to sound like I'm all in, but I am all in. I'm like trying to understand. Again, I have no conflicts, and I'm just trying to understand who are the subgroup of patients when costs do become a concern, who we should target because they're driving a lot of this average treatment effect that we're seeing here.
So, Dr. Kazi, your parenthetical statement is correct because I have no relationship with the industry either. So we're looking at this as clinician scientists and say potentially for populations that we know carry a high risk burden, and especially for patients with HFpEF, where we've not been able to modulate that natural history sufficiently well enough, these data are at least intriguing. And I agree with Dr. Kazi, we need more a priori primary well-controlled data, but these data are at least intriguing. I think you would agree with that, Dr. Kazi.
Yeah, I agree. One of the questions from the audience is, are these benefits also seen in non-obese HFpEF patients? And Dr. Yancey, you mentioned that the trial you didn't have to be to meet the strict definition of obesity. There were overweight individuals with comorbidities who were included in the trials. Would you comment a little bit on that?
It's a very important question because it challenges the definition of obesity per se. We've defined it according to body mass index, and again, select accepted a body mass index of 27. 27 really is just overweight. A lot of us probably flux up to 27, 28, 26 on a regular basis. But if you dig deeper, we need to begin to think about what that really means. And I'm delighted to tell you that we're understanding that it's not just an arithmetic formula anymore. We're thinking about the importance of visceral adiposity. That may be what's driving a lot of this. And that means that whether by imaging or by biomarkers or by just looking at waist circumference, particularly in certain populations, thinking about South Asians, we might be able to better calibrate what this definition is of medical obesity. I want to be very clear that that's the important modifier, medical obesity. but obesity not as body mass in its fullest extent, but that part of weight gain that fundamentally changes our metabolism and inclines us towards dysglycemia, the pro-atherosclerotic profile, and in part HFpEF. That really is again another segue to this whole concept of how do we go from what had been series of failures in HFpEF to the success that we're experiencing now. And I'll just remind you that going through the biology in the beginning was important to get to the relevance here. That is going from biology to relevance. I won't go through all of these potential benefits, but this is the cascade of potential mechanisms by which we're beginning to see something that at first glance was inexplicable, but it might be much less than that. So can we give you some guidance on these incretin therapies? Well, Josephine Harrington and Amanda Vess and others published a paper in Circulation Heart Failure just about a year ago that was trying to help us understand where the guidelines were. I'm the senior author of the ACC, AHA, HFSA Heart Failure Guidelines, the new data since we published them in 2022, and the data to come. And you can follow through. And I think it's really important to recognize that we've always recognized the importance of obesity, as in avoid obesity to prevent the development of heart failure. That's all phenotypes. I'll say that again. That's all phenotypes. We know the trioca of hypertension, obesity, and diabetes accounts for the majority of heart failure, particularly in special populations. Weight loss is a reasonable strategy to improve quality of life. That's been well delineated now by STEP HFpEF. We know that weight loss in patients with a very significant BMI might improve exercise capacity. And then we understand that even a modest reduction is of benefit. All of that is embedded in the guidelines as they exist. But since we wrote those guidelines and released them in 2022, we've had STEP HFpEF and STEP HFpDM, the meta-analysis. We've had the important SELECT trial, which Dr. Kazi and I have reviewed. We're waiting for the full analysis of the heart failure phenotypes from SELECT. SURMOUNT is yet another important trial, and we've gone over the SUMMIT data. As Dr. Kazi and I talked about in our pre-meeting prior to this webinar, these data points are coming at us very quickly, and the field is changing fast. So we need to be very facile with this information data set. From Steve Green, David Butler, and Greg Fonarow, published in JAMA Cardiology just months ago, we now get this sense of a very different way of approaching HFpEF with these three evidence-based therapies, the SGLT2 inhibitors, the non-steroidal mineralocorticoid antagonists, and the GLP-1s in a setting of being overweight or obese. And you can see the concomitant other therapies. This is an important enough graphic that I'm going to leave it here for just a minute, thinking about the green boxes where we have a priori evidence-based literature to support the use. And then the additional, if you will, orange boxes. We know that ARNI is an indicator for anyone without a normal ejection fraction. The steroidal MRAs may work for those that can't take the non-steroidal, steroidal being spironolactone, and pleuronone, the non-steroidal being finerenone. And for some patients with this mid-range ejection fraction, we believe that the evidence-based beta blockers may play a role there. But cogitate on this graphic because it's beginning to frame an approach to HFpEF and heart failure with mid-range ejection fraction that now is in parallel with heart failure with reduced ejection fraction. This is yet another recommendation of how you can approach the patient with heart failure and the patient in the general population as a function of their body mass index, inclusive of lifestyle changes and bariatric surgery recommendations. What about in women? This is very important information, and Dr. Anu Lala from Mount Sinai was instrumental in bringing these data forward. But realize that women experience more weight reduction in response to GLP-1 therapies and HFpEF than men. Similar improvements in the markers that you see to the right in the upper panel, but there are other additional considerations that we must not forget, particularly in the perimenopausal space, understanding how dynamic that physiology happens to be. And this really invites significant more therapy, significant more research, significant more application to understand how best to use these agents in that unique setting. want to get to the cost of
Dr.
care.
Yancey, before we move on, there's an audience question
Sure.
specifically about GLP-1 use in women. Can I just chime in with
Yes,
a
please.
couple of comments? One is that if you look at the real world data, women form the majority of users of GLP-1s in the country, which is not surprising given that there is a very clear difference in the prevalence of obesity by gender in the US. So you see more use. There's not differential adherence. There's a signal that women are less likely to discontinue therapy, but the differences are small. And then at least not in the context of HFpEF, but in other contexts, there are not major gender differences by on effectiveness. So your point, there was a question from the audience about what do we know about these drugs and the differences? And I would just say women use them more, they're more likely to stay on them. Clinically, we don't see the difference. And it remains to be seen whether, as Dr. Yancey pointed out, all of these other benefits of GLP-1s make them more salient or more beneficial in women.
Dr. Kazi, thank you. Are there other questions in the chat? I'm
Yes,
really happy that you're reviewing those chat questions because we can take those now before we go into the cost of care.
there's one other one that I think or a couple that might be helpful to tackle. One of them is which GLP-1 is best for heart failure patients? Specifically, what about oral GLP-1s? And are the outcomes expected to be similar to injectables?
So a couple of things about the development of the GLP-1s. It turns out that the beginning of the introduction of these therapies, administration of GLP-1s led to significant nausea, so much so that patients just couldn't tolerate the drugs. Moreover, these are peptides. Peptides do not lend themselves well to enteral digestion, meaning pill form. So the parenteral approach was beneficial twofold. One, we didn't have to worry about the enteral administration and the difficulty with digestion. And two, we can only expose patients periodically to the nausea and vomiting. That's been a part of the drug profile from the onset, and maybe that will get better. The good news is that there is an oral semaglutide that is now available, but the dose is quite low. And so we need to think about whether or not that is a sufficient dose to modulate these effects in a setting of HFpEF, because I think Dr. Kazi again gave us a nuance that was not insignificant. If you looked at the summit results, the curves didn't separate until 6 months. So at least chronologically, weight loss had sufficient time to occur. Now, was weight loss responsible for the benefit? Was it weight loss plus the biology that we've reviewed? That requires further study, but we can't separate out weight loss from the benefit in HFpEF. And so I'm worried about the lower dose in the pills being able to replicate the same benefits we've seen so far, but it's worth prospective investigation. What do you think, Dr. Kazi?
I think I totally agree. A couple of things to note about semaglutide in particular, that we as clinicians have this intuition that people prefer pills to injectables, but there are two clear signals in the data. One is that the adherence is similar. If anything, the pills have worse adherence than the injectables. The side effects are more with the injectables I'm sorry, with the orals because you're taking the pill every day versus you're taking your injectable once a week. So we don't clearly see an adherence benefit of oral versus injectable. What we currently in the US do not see a cost differential between the two. So they're pretty much available at the same price. And as we talk about the economics, that becomes important. In other parts of the world, there is a cost differential. And so if you look at Japan, the cost differential is enough where the majority of users of GLP-1s are using oral drugs. But in the US, we don't see that delta. So I'm not fully convinced that outside of a patient who really hates needles, does not want to take any injectables, and will say oral or bust, that there is a clear benefit to switching to orals.
All right. We're going to close out this webinar by offering you a few perspectives on limitations to care. One is the cost of care, and the other is the side effect or risk profile. For this cost of care, no one in this room is unaware of the substantial costs and ultimately health economic burden represented by these drugs. Retail is still about $1,000 per month. This is one analysis published within the last 6 months in the JAMA network full disclosure, I'm one of the editors in the JAMA network, so I have access to the information, but similar analyses have been reported elsewhere. It demonstrates, first of all, what kind of spin we've seen on the glucagon-like peptide 1 receptor agonist in the US. I want you to pay attention to the number I'm going to show you. $72 billion in 1 year. That's a stunning number, a stunning number. Now, Dr. Kazi really is one of the nation's experts in understanding cost effectiveness of therapeutics. So I'm going to show you a typical model we use to simulate benefits here. We try to understand what are the risks, what are the tangible benefits, and we weigh the benefits, quality of life, morbidity, and mortality. And we put that in a calculus based on the price of the drug that allows us to make an assessment. Traditionally, that assessment has been a metric that Dr. Kazi and I know as quality adjusted life years. A more contemporary metric, though, is willingness to pay, understanding that there may be some distinction because quality adjusted life years was originally predicated on the cost of hemodialysis for a year. Now we're thinking about the willingness for a system to pay. These cost-effectiveness data compared the non-incretin weight loss therapies versus semaglutide and tirzepatide. At a willingness to pay of $150,000, neither tirzepatide in gold or semaglutide in green reached that tier. Even at a willingness to pay of $200,000, tirzepatide was still slightly above, and semaglutide significantly above in terms of incremental costs. If you now reverse the calculus and say, okay, what kind of price reduction will be necessary to get that willingness to pay to a reasonable threshold? Remember, the willingness to pay thresholds are higher than what we would call the qualities. You can see that for semaglutide, it would be an 82% price reduction. For tirzepatide, about a 30% price reduction. So these are our realities. Will this change with oral therapies? Will this change eventually with generics? Almost assuredly so, but these drugs are protected until the 2030s. Will this change with compounding? That's another question. We had brief exposure to compound pharmacies and compounding. That's no longer the case, but these are important data. Yet before we go forward, I think they're so important that I'd like to welcome again Dr. Kazi's expertise to comment on these data. He and I are aware of other more recent quality analyses, and we're waiting to see more of those data come to full fruition. Dr. Kazi?
Thank you, Dr. Yancy. So, I mean, as you point out, the economics of these drugs is stunning. If you look at 2024, semaglutide and tirzepatide were the #1 and #2 drugs in the US. Even after you account for rebates, they're at least in the $30 billion range and growing. So really big strain on the health system in terms of spending. I will say that when we look at cost effectiveness, the population that is being considered is really important. And so this analysis is on all individuals using the drug as anti-obesity therapy. That is the lowest risk group that uses this set of drugs. And so if you go from anti-obesity to I would say in between would be diabetes, then there's heart failure, and then there's the pre-existing ASCVD. So that group being at the very top. At the higher the risk, the more you're willing to pay for a certain therapy because the absolute benefits increase. So I think in the heart failure group, the thresholds will be different from what we're seeing, but it's unlikely that they are cost effective at the current list price. Semaglutide was selected for price negotiation by Medicare, and so starting in 2027, we expect to see reductions in semaglutide prices for at least for Medicare beneficiaries. And I think I'm hopeful because that is a big group of people with heart failure and cardiovascular disease in general, that will improve the economic efficiency of these therapies.
Dr. Kazi, thank you. I'm delighted that so many of you have stayed with us. We still have well over 200 of you listening, 230, and we're simply going to review the risk and then close this webinar. The risk, as we know them, are the following: gastroenteritis, pancreatitis. I've seen that in my own patient population. This is a major risk. This sarcopenic risk, muscle loss and lean body mass loss. And I'll invite Dr. Kazi in a minute to comment about this because this may be a real challenge. Cholecystitis is rare but real. Thyroid C-cell tumors even more rare. Hypoglycemia does occur. Renal injury unlikely. Interesting, even though we're required to divulge suicidal ideation, there's some data that have demonstrated a reduction in suicidal intention in some of the trials where the data are captured. Injection site inflammation is not unexpected. And delayed gastric emptying is a little bit of a clinical nuance you need to appreciate. Gastroenterologists, I'm sorry, anesthesiologists see this all the time and really require that the therapies are held at least 2 weeks before general anesthesia is administered because the delay in gastric emptying is a real prominent feature and it makes recovery from general anesthesia very difficult. But Dr. Kazi, talk to us about muscle loss before we close this webinar.
I mean, the muscle loss, between 20 and 30% of the weight individuals lose while on therapy is muscle. So it's not just all fat. And the alarming part of it is if you stop the therapy and the weight all comes back, what comes back is all fat. And so even though you may end up at the same weight that you started out with, now your body composition is a lot worse. And which is why there's a big push to couple GLP-1 therapies with exercise. There was a question in the audience, but well, can we use cardiac rehab? And as you know, cardiac rehab for HFpEF is not covered by most payers. We're hoping to change that, but currently I'm not aware of payers that are supporting cardiac rehab for this population. But I think it would be extreme. It's necessary when you start this therapy to make this recommendation that it's not just any exercise, but like muscle strengthening exercise that should be started along with GLP-1s.
Really has been a pleasure to bring this information forward. I hope that you've appreciated the way in which we've developed this content. We've tried to endorse the importance of evidence over the last many decades to really help us understand how best to approach heart failure with reduced ejection fraction, and then to mirror that evidence generation process, applying it to HFpEF. We wanted to really hone in directly on what we think is a breakthrough of landmark consideration, appreciating the incretin therapies and the role they may play in HFpEF, a role that's already been validated by clinical trials, not yet on survival, by the way, but on morbidity. I thought it important that we not just accept the drugs as they are, but we kind of think about the biology. How did we get here and why might these benefits be as they are? With Dr. Kazi's help, we wanted to go through the clinical trial data, understand the nuances. We wanted to particularly appreciate the distinction between weight-related benefits and weight-independent benefits. I really value his contribution to helping us understand the healthcare economics of these admittedly expensive therapies, but admittedly profoundly beneficial therapies. And it was important that we went through the risk of these therapies. It's not beneficial to withhold those risks. We have to make decisions at the bear side and the chair side all the time about risk benefit, and we want to be very forthcoming, very transparent with that. We still have time remaining, so I would like to continue to invite your questions and answers, but I want to personally thank Dr. Kazi for being with us through this webinar. And I want to thank Natalie Navarro, who behind the scenes coordinated this entire exercise. She and Lisa Larson did a brilliant job putting this together. Perhaps it's important for Natalie and Lisa to have a moment before we go further with our Q&A.
Thank you so much, Dr. Yancy, and thank you, Dr. Kazi. This is really stimulating discussion, and we try in Get With the Guidelines Heart Failure to really stay abreast with all of you all's, clinical expertise. With all of your help, we try to stay abreast of the newest trials so that we can be implementing these data elements and really pushing better and more care for all of our heart failure patients. I would like to say that I think that there were a few points that really stuck out to me. One had to do with weight dependent versus weight independent. And I think that this is incredibly important for us to remember, that it's not all about weight, because we do know that our larger patients do go in to clinical visits and oftentimes feel judged simply because of their weight, or feel like they're not getting the full breadth of available therapies. because their weight is being prioritized over some other symptoms. So I think this is a really nice shift in saying that it's not fully weight dependent as far as outcomes, so that people can feel like their whole person is being accounted for. Again, not to say that, as we all discussed, weight is not an issue, but I think the more that we can make all patients feel included and inclusive, that is really going to drive outcomes. And I wanted to thank everybody who does participate in Get With the Guidelines Heart Failure, or potentially one of our other modules. And on the next slide, Dr. Yancey, if you would advance one, there's a QR code if you all do not currently participate in the module, and we would be oh, sorry, there's not a QR code on this one, but please feel free to visit heart.org/quality if you'd like to find out more about our suite of Get With the Guidelines programs. So that is all that I wanted to throw in there, besides just, again, a very, very heartfelt, pun intended, thank you to both of you clinician experts.
Thank you for that. And for this final question in the chat, yes, for every webinar we do within Get With the Guidelines, we archive the webinars so you can return, revisit what Dr. Kazi and I have suggested or shared with team members that weren't able to participate today. So once again, critical mass still remains with us, well over 200. So thank you. It's been a real pleasure, and we hope that you'll continue to support not just Get With the Guidelines Heart Failure, but the American Heart Association as well. We continue to relentlessly work on making a difference in heart disease throughout the country, throughout the world. Thanks very much for joining in today.